thank you. So this morning I'll be talking about the surgical management of craniofacial fibrous dysplasia. All right, so here's a brief outline for the talk today. So I'll start with just a short background on craniofacial fibrous dysplasia, and then we'll move on to review some of the goals and indications of surgery. Then we'll move on to kind of the bulk of the talk will be the principles of surgical management of craniofacial FD. I'll highlight some region-specific considerations, and finally I'll close with a couple comments on the potential role of denosumab as a medical adjunct to surgery. So craniofacial FD is common. It's reported in up to 90% of polyostotic cases of FDMAS, and it can account to up to 25% of monostotic lesions. The most common sites are the anterior skull base and the gnathic bones in polyostotic FD, and the zygomatico-maxillary complex in monostotic lesions. Craniofacial FD can be associated with significant morbidity, and patients can have visual changes, hearing loss, facial asymmetry, and malocclusion. And the morbidity associated with craniofacial FD is largely related to FD expansion. So lesions kind of expand in a defined space, leading to obstruction and compression of vital neural structures, and ultimately this is what leads to morbidity. And to date, there are no effective medical therapies that halt FD expansion, and thus the mainstay treatment for craniofacial FD is surgery. So the goals of surgery are outlined here. First, it's the prevention of functional loss. Then it's the reduction of any sort of physical disfigurement, prevention of secondary deformities, and finally, minimizing the long-term morbidity of both the disease and its treatment. So I made this table that kind of outlines, not comprehensively, but most of the indications for surgery in craniofacial FD. And as you can see again, any sort of sequelae that results in a functional deficit or any severe asymmetries or contour abnormalities would be indications for surgery. And that's when it's really reserved for. So we'll move on to the principles of surgical management. We'll talk about preoperative optimization, timing of intervention, and finally close with some surgical techniques. So a multidisciplinary team approach is essential for pre-op optimization in craniofacial FD surgery. So first, really screening and treatment of any endocrine abnormalities, especially those that exacerbate the skeletal disease, is really important. And then you can also consider doing preoperative embolization for any anomalous vasculature. We have found that FD lesions are hypervascular, and therefore pre-op embolization can result in decreased blood loss intraoperatively. Understanding the progression of FD is really critical for determining the optimal timing of surgical intervention. And so historically, when we think of how we describe FD progression, there are kind of two schools of thought. We can either use total disease burden, which is where we measure the total amount of skeletal disease from bone scans, and this is estimated using the skeletal disease burden score. Or we can think of it in terms of disease activity, which is the actual metabolic activity within an FD lesion. However, both of these kind of measures of progression really reflect global disease burden and are less relevant for the craniofacial region. Instead, looking at FD progression in terms of lesion expansion is more relevant because, again, lesion expansion is what really causes the morbidity associated with craniofacial FD. So recently we published this paper looking at lesion expansion in gnathic FD lesions. And the goals of the study were really to characterize the natural history of FD lesion expansion and identify risk factors associated with increased volumetric expansion. So we looked at 106 gnathic lesions from 52 patients, and these were evaluated on serial CT scans. In total, we looked at 499 CTs. And again, these were of FD lesions involving the mandible and the maxilla. And so here is the graph of the main findings, which is, you can see it's a lesion volume over time. And you can see that FD lesions tend to grow during childhood and adolescence and then stabilize after the second decade of life. We found that growth hormone excess was associated with an increased rate of FD expansion. Also that there were differences in expansion rate between by location. So mandibular lesions tended to expand at a greater rate than maxillary lesions. And then finally, and importantly, we noticed that bisphosphonates did not have a significant effect on lesion expansion. And so these findings would suggest that the optimal time to intervene surgically for these lesions would be after the second decade of life, during adulthood, when expansion has stabilized. Moving on to surgical techniques. So really you can kind of break this down into two main categories. There are either more conservative debulking or shaving procedures versus more complete radical resections of lesions. And so we previously looked at the outcomes of these procedures in craniofacial FD and noted that debulking procedures are associated with significantly higher rates of regrowth and reoperation compared to more complete resections. In addition, they found that growth hormone excess was again associated with higher rates of regrowth postoperatively, and that reoperation was more common after surgeries involving the gnathic bones. And so these findings would suggest that the most definitive treatment for craniofacial FD is a more complete resection. However, debulking procedures can still be performed in cases where the surgical morbidity associated with complete resections would be deemed too high, or if surgery was indicated in a pediatric patient that was still growing. Next, it's important when you think about techniques as you think about the reconstructive options after a resection. And so bone grafts are frequently used in FD to promote bone healing and to offer greater stability after a resection. And the data in craniofacial FD is really limited. However, previous studies from outcomes in orthopedic surgery show that bone grafts, both autologous and allogenic materials, have high rates of resorption when they're grafted within FD lesions. So this is, for example, after a curettage procedure. In addition, they found that resorption rates are significantly higher in the pediatric population. And so these findings would suggest that to increase the probability of bone graft survival and incorporation, it would be best to do after a complete resection of a lesion. And so just to summarize kind of the surgical principles first, preoperative optimization is really important, and control of growth hormone excess is essential due to its contribution to the risk of regrowth and reoperation. For timing of surgical intervention, if possible, surgery should really be delayed until after the age of skeletal maturity, preferably after the second decade of life when FD lesion expansion declines. And that, unfortunately, aggressive lesions that are associated with functional deficits, they may require earlier intervention in pediatric patients. And then ultimately, complete resection is the most definitive treatment. However, temporizing debulking surgeries can be performed if secondary deformities arise, and just kind of temporize the lesions until definitive reconstruction can be performed. And then finally, when it comes to bone grafts, really there's high rates of resorptions, and so autologous bone grafts especially should be used judiciously, and if possible, saved for the definitive reconstruction. So next we'll move on to just highlight some region-specific considerations. I won't go into much detail, but essentially there was a prominent paper that came out of Changgung Memorial Hospital outlining the different techniques for management in the craniofacial region, and they kind of broke it down by these zones. So zone 1 is the upper 2/3 of the face, the frontal bone, orbits, and upper maxillary region. Zone 2 is the hair-bearing cranium. Zone 3 is the central skull base, and zone 4 is the tooth-bearing segments of the gnathic bones. And so generally for zones 1 and 2 of the face and calvarium, complete resection is recommended if possible. And in zones 3 and 4, debulking procedures are favored, and this is particularly important in zone 4, where the preserving the native dentition is really prioritized, and therefore debulking would be preferred over a complete resection. This flow chart is from a subsequent paper out of from the group at the Hospital for Sick Children in Toronto, and it's kind of a similar concept, slightly more nuanced, and I won't go into detail on it for time, but I will highlight that they specify treatment algorithm for orbital apex disease because this has historically been a controversial aspect of the management of craniofacial FD. And so previously, prophylactic optic nerve decompression surgeries were performed for any disease involving the optic canal. However, this surgery itself was associated with high morbidity and vision loss postoperatively. And it's now pretty well established that having FD surrounding the optic canal alone doesn't necessarily result in vision loss, and therefore prophylactic optic nerve decompression just for narrowing is not recommended. In contrast, therapeutic optic nerve decompression surgery is reserved for patients with acute marked vision loss. At the last consortium meeting, I presented some of the data from a study we did on the management of optic neuropathy and FD, and those results have now since been published in JBMR, and it was focused on using a optical coherence tomography testing, or OCT testing, to monitor for symptoms of optic neuropathy. And so OCT is a non-invasive imaging modality that's used to monitor the retina and the optic nerve. One of the measurements that you can take from OCT is measuring the thickness of the retinal nerve fiber layer, or the RNFL. So the retinal nerve fiber layer is the layer of your retina that consists of the axons that all go on to converge to form the optic nerve. And so when you see thinning of this layer, that represents axonal injury and optic nerve atrophy, which would be consistent with optic neuropathy. So we found that OCT measurements of RNFL thickness, they accurately can identify optic neuropathy in FD with high sensitivity and specificity using the diagnostic criterion of the layer thickness less than or equal to 71 microns. We also looked at the age-related changes in RNFL thickness in the FD population, and we found that patients with normal vision exhibit similar trends to the rest of the population, where overall RNFL thickness tends to decrease with age. However, patients with optic neuropathy show a rapid loss of RNFL thickness, and this difference was most noticeable in the pediatric population. When we look longitudinally at this data, you can see that children initially have an increase in RNFL thickness during times of growth and puberty, and then we don't actually see a decrease in the RNFL thickness until the third decade of life. And this is in contrast to patients who develop optic neuropathy during childhood, in which they have a rapid decline. And so these findings would suggest that any decrease in RNFL thickness during childhood could represent impending optic neuropathy, and that those patients should be monitored closely for impending optic neuropathy. And so finally, I'll close with some comments on the potential use of denosumab as a adjunct therapy. And so there's a growing body of evidence to suggest that denosumab is effective in treating FD. Our lab recently completed a phase 2 clinical trial using denosumab to treat FD, and I won't go into detail about the results because Dr. Boyce will be speaking on that a little later this morning. But in brief, we found that denosumab treatment reduces the activity within FD lesions. However, it does not appear to reduce the volume or the expansion of lesions. Ultimately, further studies have to be performed to see if there's an effect of denosumab on lesion volume, particularly with longer follow-up time and in younger patients. However, if it is proven that denosumab had a role in halting lesion expansion, it could then have a role as an adjunct therapy to surgery. It could be used potentially in two ways. First, as a neoadjuvant therapy, so prior to surgery, and this could be used for lesion stabilization to prevent secondary deformities prior order to delay surgery until skeletal maturity or until adulthood, when the definitive surgery could be performed. It could also be used as an adjuvant therapy after surgery, and so this would be particularly useful to prevent postoperative regrowth in pediatric patients if a debulking procedure needed to be performed. Again, though, further studies are needed to first show the effect on expansion before we can kind of elucidate more on its role as an adjunct therapy to surgery. So with that, I'll close, and I just want to thank my lab and my mentors at NIH.
Great. Any questions?
Thank you very much for this really brilliant talk. I would like to ask a question regarding optic nerve decompression. In general, we tend not to operate preventively and try to operate those who are losing sight, or if their OCT numbers are declining. However, some surgeons say that, in fact, it's also depending on the aspect of the optic canal, in particular the thickness of the bone surrounding that. So do you think that when there's really a thick bone around the optic canal, this should be a contraindication to surgery, or would you try to do it anyway?
I don't necessarily think it would be a contraindication to surgery. I think in the setting of acute vision loss, surgical intervention is kind of the only option in order to prevent, long-term blindness. However, I do think that especially when the bone is very thick, then you have increased risks of thermal damage related to surgery itself. And so, it's kind of if you don't operate, you don't do anything, most likely it will result in blindness. And if you do, there's also a risk as well. So I think that is a dilemma, but ultimately I think most people would agree you'd rather try to save the vision rather than do nothing.
Is that a quick question, Stan? Quick question?
A quick question, and we will discuss later if you like. So there's a lot of evidence that if the optic nerve is compressed and you have decreased retinal nerve fiber layer thickness, there's less chance of recovery of the optic nerve. So if you say that the thinning of the RNFL is an indication for surgery, it's still very unpredictable whether you will actually help the patient.
Yeah, so that's what and sorry if I misspoke at all, but I wouldn't say thinning of the RNFL in general is an indication for surgery. I think that ultimately we do need more studies on that. It's true that in the literature, especially for pituitary adenomas, when there is a compressive injury at the level of the optic chiasm, patients tend to have a better prognosis for visual recovery after surgery if their RNFL layer is thicker preoperatively. So that kind of comes to your point about the importance of early diagnosis and early intervention in order to maximize the chance of visual recovery postoperatively. And so one, I think, potential indication would be patients who already have moderate vision loss and demonstrate, a pattern of thinning of the RNFL layer. It actually might be an indication to perform a decompression surgery in order to maximize the likelihood of functional recovery. However, again, those studies are done in settings of pituitary adenomas at a different level of the optic nerve at the chiasm rather than the canal. And so I would say we need further, studies to actually.
The studies also have been done in meningiomas and orbital tumors. So there's really a lot of evidence, but we'll discuss later.
Okay, thanks.